Welcome back to my YouTube channel. If you are new to my channel, welcome to MedCode Insight. Hi, I am Nishaba, a certified medical coder. In this video, we will explore the key codes related to axillary sinus, one of the most important part of the respiratory system, and larynx. We will cover important guidelines and provide practice questions to help you to better understand this essential topic. Let's dive in and get started. There are four bilateral sinuses: the frontal, ethmoid, sphenoid, and maxillary sinus. Each pair is systematically located on both sides of the face and skull. Here are some important coding guidelines we need to know while coding for endoscopic procedure done on accessory sinuses. Code 31231 to 31235 for diagnostic evolution involve inspection of the anterior of the nasal cavity, the middle and superior meatus, the turbinates, and sphenoethmoid recess. A separate code is not reported for each area if all these elements are inspected. When all of the elements are not fully examined, use modifier 52 if repeat examination is not planned, or use modifier 53 if repeat examination is planned. A surgical sinus endoscopy includes sinusotomy when appropriate and diagnostic endoscopy. Code 31233 to 31298 are used to report unilateral procedure unless otherwise specified. Code 31231, 31233, and 31235 are used for diagnostic purposes. Code 31231 is used for both unilateral and bilateral procedure. Code 31233 is used for nasal sinus endoscopy diagnostic with maxillary and sinuscopy, while code 31235 is used for nasal endoscopy diagnostic with sphenoid sinuscopy. Code 31254 to 31259 refer to nasal sinus endoscopy surgical with ethmoidectomy. In the surgical procedure, the ethmoidectomy may be partial or total. If only the anterior portion is involved, it is considered partial. If both the anterior and posterior portions are involved, it is considered total. Code 31276 is used for nasal sinus endoscopy surgical with frontal sinus exploration, including the removal of tissue from the frontal sinus when performed. Code 31287 is used for nasal sinus endoscopy surgical with sphenoidotomy when sphenoidotomy is done with the removal of the tissue from the sphenoid sinus. Use code 31288. Code 31290 and 31291 are used for nasal sinus endoscopy surgical with repair or cerebrospinal fluid leakage in the ethmoid or sphenoid region. Code 31292 and 31293 refer to nasal sinus endoscopy surgical with orbital decompression. If the procedure involved the medial or inferior wall, use code 31292. If both the medial and inferior walls are involved, use code 31293. Code 31294 is used for nasal sinus endoscopy surgical with optic nerve decompression. Code 31295 to 31298 are used for nasal sinus endoscopy surgical with dilation. Use code 31295 when the ostium or opening of the maxillary sinus is dilated. For the dilation of the frontal sinus ostium, use code 31296. For sphenoid sinus, use code 31297 when performed on both frontal and sphenoid sinus ostia. Use code 31298. Code 31360 to 31368 are used for the open removal of the larynx, which may be total or subtotal with or without radical neck dissection. Here are some important coding guidelines we need to know while coding for endoscopic procedure done on the larynx. Endoscopic procedure report the appropriate endoscopy for each anatomic site examined. Laryngoscopy includes the examination of the tongue base, larynx, and the hypopharynx. For reporting, all pair structure on one side of the larynx or pharynx are considered unilateral. If using operating microscope, telescope, or both, use the applicable code only once per operative session. Laryngoscopy procedure may be performed direct, indirect, flexible, or with flexible or rigid telescope. Code 31505 to 31513 are used for indirect laryngoscopy. Code 31515 to 31571 are used for direct laryngoscopy. For direct laryngoscopy, always remember not to code for the operating microscope separately. Code 31575 to 31574 are used for flexible laryngoscopy and code 31579 with flexible or rigid telescope. The patient is seen in the endoscopy suite for a diagnostic maxillary sinusotomy. During the sinusotomy, the provider observes some diseased tissue which needs to be removed. The provider decides to perform a maxillary enterostomy with tissue removal. Bleeding is controlled, the patient tolerated the procedure well, but CPT codes are reported. Option A with code 31231, 31267. Option B with code 31254, 31256. Option C with code 31256. Option D with code 31267. In the given scenario, a diagnostic maxillary sinusotomy is performed along with maxillary enterostomy and tissue removal. Always remember, a surgical sinus endoscopy includes a diagnostic endoscopy. First, we will eliminate option A with code 31231 used for diagnostic procedure. Since the procedure was done on the maxillary sinus, we will also eliminate option B, which uses code 31254 used for surgical procedure involving the removal of ethmoid sinus. Since the surgical endoscopy is done with maxillary enterostomy and tissue removal, our correct option is option D with code 31267, which is used for nasal or sinus endoscopy surgical with maxillary enterostomy and removal of tissue from the maxillary sinus. The pulmonologist in the multispecialty group refer a patient to the otolaryngologist because he thinks that the shortness of the breath that the patient is experiencing may be due to sinusitis and laryngopharyngeal reflux. The otolaryngologist decide to perform a rigid bilateral nasal endoscopy to get a better look at what is going on in the sinuses and a flexible laryngoscopy to determine if LPR is contributing to the problems because he could not get adequate visualization on manual exam. First, the bilateral nasal endoscopy is performed and the otolaryngologist diagnoses chronic pansinusitis. Next, a flexible fiber optic laryngoscope is introduced nasally and the larynx and the trachea are inspected. The diagnosis is chronic laryngitis or tracheitis and LPR. He prescribes singular anesthesia and proposed endoscopy surgery will be considered in the future if the current treatment does not fully take care of the problem experienced by the patient. But CPT and ICD 10 codes are reported for the procedure. Option A with code 31575, 31231 along with modifier 59, J32.4, J37.1. Option B with code 31575, 31231 along with modifier 50, 59, J32.4, J37.1. Option C with code 31576, 31231 along with modifier 51, J32.4, J02.9, J41.8. Option D with code 31576, 31237 along with modifier 50 and 59, J32.4, J37.0, J41.8. In the given scenario, a rigid bilateral nasal endoscopy is performed along with flexible laryngoscopy to diagnose the problem. Since no surgical procedure is performed, we first eliminate option C and D, which uses code 31576 used for surgical procedures. In both option A and B, code 31575 is used for flexible laryngoscopy for diagnostic purposes. Code 31231 is used for nasal endoscopy, diagnostic unilateral or bilateral, and there is no need to add modifier with this code. Therefore, option B, which includes code 31231 along with modifier 50, is incorrect. The correct option is option A, which includes code 31575, 31,231 along with modifier 59, J32.4 and J37.1. Code 31,231 is listed as a separate procedure. Therefore, modifier 59 is appended. These procedures are indeed separate because a nasal endoscope was used and then the provider used a flexible laryngoscope. Patient with partial vocal cords paralysis requires bilateral removal of arytenoid cartilage to improve breathing. The laryngoscope with operating microscope is inserted. Adequate visualization is established and arytenoid cartilage is exposed by excision of the mucosa overlying it. What diagnosis and procedure codes are reported for this procedure? Option A with code 31,561, 69,990, J38.02. Option B with code 31,561, J38.02. Option C with code 31,560, J38.00. Option D with code 31,560, 69,990, J38.02. In the given scenario, a laryngoscope with an operating microscope is inserted for the removal of arytenoids. In the CPT index, both codes 31,560 and 31,561 are listed for laryngoscopy direct operative with arytenoidectomy. Code 31561 is appropriate for a direct operative laryngoscopy with arytenoidectomy using an operating microscope. Therefore, we will eliminate option C A D, which uses code 31560 for laryngoscopy direct operative with arytenoidectomy but without the use of operating microscope. Since code 31561 already includes the use of an operating microscope or telescope, and it is also mentioned in the parenthetical note under code 31561 that states do not report code 69,990 in addition to code 31,561. There is no need to add code 69,990. Therefore, our correct option is option B with code 31,561 along with code J38.02. Patient has endoscopic surgery done to remove his anterior and posterior ethmoid sinuses. The surgeon dilated the maxillary sinus with a balloon using transnasal approach, explored the front sinuses, removed two polyps from the maxillary sinus, and then performed the tissue removal. Option A with code 31,255, 31,295, 31,237. Option B with code 31,201, 31,295, 31,237. Option C with code 31,255, 31,267. Option D with code 31,255, 31,295, 31,267. Since the procedure is an endoscopic procedure, we first eliminate option B with code 31201 describe an open ethmoidectomy, and in our scenario it was performed endoscopically. In option A, code 31,237 is a separate procedure, which means if it was performed at the same time as another procedure, then it can't be coded and is bundled into the primary procedure. This means option A can also be eliminated because this code is listed. In option C and D, code 31,255 is correct and accurately describe an anterior and posterior or total removal of the ethmoid sinus. Code 31,295 in option D also performed and correctly coded. However, beneath the code, there is a notation that it should not be reported in conjunction with code 31267, which is one of the correct code in the answer to. Code 31267 describes the nasal polyps removal, and since we know that it can't be used in conjunction with code 31295, so our correct option is option C with code 31255 and 31267. A patient with a diagnosis of chronic sphenoidal sinusitis undergoes a bilateral sinusotomy. While the provider examines the diseased sphenoidal sinus, she takes a biopsy of the sphenoidal masses and removes the mucosa with several polyps. Transeptal sutures are placed and the intraoral incision is closed in a single layer. The nose is packed and external nasal dressing are placed. What CPT and ICD 10 codes are reported. Option A with code 31237 along with modifier 50 J32.3. Option B with code 31288 along with modifier 50 J32.9. Option C with code 31090 30115 along with modifier 5051 J32.9. Option D with code 31051 along with modifier 50 J32.3 J33.8. In the given scenario, a patient with chronic sphenoidal sinusitis undergoes a bilateral sinusotomy. A biopsy of the sphenoidal masses was taken along with the removal of mucosa containing several polyps. Since the procedure was an open procedure and not performed endoscopically, we first eliminate option A and B with code 31237 and 31288 being used for an endoscopic procedure done on the ethmoid sinus. We will also eliminate option C with code 31090 used for sinusotomy unilateral 3 or more paranasal sinuses. So our correct option is option D with code 31051 used for sinusotomy sphenoid with or without biopsy with mucosal stripping or removal of polyps. Modifier 50 is appended to indicate the procedure was performed bilaterally. Thank you for watching. If you have any question or need further clarification, please feel free to write in the comment section. For more detailed guidelines, CPC mock exam related questions and notes, email me at the giving email ID.